All right, so we're ready for you to go ahead and begin your slide set for the morning. Again, this is Jim Lowe. He's with the Veterinary Medicine College here on the University of Illinois campus. Jim, your presentation.
Yeah, thanks everybody. And I wanted to spend some time today really talking about, I think, these kind of four key questions, which are why do we care about this and what does it mean? And so we've got some really interesting data there. Talk a little bit about zoonotic and where we think this virus came from and why does that do that and how did that happen? I'm going to talk a little bit about why we're all locked up at home and some theories behind that. And clearly there's some chatter in the news on a daily basis about should we or should we not be here in Illinois, right? We're all supposed to be sheltering at home or stay home order or whatever the official wording is. But we're certainly not working at the university. As we chatted before this started, we don't have students here. So why are we doing that? What's the science behind that? And then just a few comments about what's going to happen in the food supply chain. And my background is really almost exclusively with the swine industry and still heavily involved in the swine industry. And what are we talking about there and what are we chatting? And probably a little bit about what do we think that might do for corn and soybean prices long term, because it certainly could have some dramatic impacts on what our industry looks like. So just pulling up some data, and this is really an estimate out of the Imperial College. It came out about last week. And as a scientist, you spend a lot of time reading these days because there's so much new data every day. But along the x-axis is age groups. Along the y-axis is the number of cases or severity of cases. So if you look at that, right, the original story is that old people have got a problem and old people are going to die. And that's kind of true, but not completely true. And what you'll notice is that there's that orange line, which is the number of people that are infected that end up needing hospitalization in critical care is quite high when you get older. So, and that makes sense because you've got people with comorbidities or other diseases, and that tends to accumulate as we get older. And as I'm getting older, this all strikes home a little bit more. I'm certainly to the right of the graph, not the left of the graph anymore. And so what you see is that when people above 70 or 80, half of those or something more than that require extensive critical care. And then if you look at the blue line to the right there, right, 20, 30, 40% of those people are going to end up requiring some kind of hospitalization if they're infected. So this is somewhat significant. We now are starting to really worry about what's going to happen with hospital overruns. I think the black line represents how many of those that are infected die. And we're going to talk about testing in a minute. But one of the big challenges with what we're dealing with this whole case now is what's the case definition? So we talk about there's X number of cases, but that's really the number that of people who have been tested and tested positive. And we know that's a gross underestimation of the number of people that are infected in the country. And so we've got some real challenges with what the denominator is. But I think the point being all age groups are affected and all age groups can be affected significantly. And we certainly have seen now cases, particularly look at Italy, of younger people being severely ill and passing away from the disease. So this is a website you can go to. It's quite intuitive. It's quite interesting. It's covidactnow.org. And it lists which states are going on. And you can see the green states are the ones where we think that we need to stay at home. And the orange states are where they think we should only do shelter distancing. And the red states are not paying attention, apparently. And so we'll just ignore what's going on in those states. But the green states are saying, hey, this is somewhat severe. And the big point of this website is really talking about why do we need to be so severe. And if you just look at the state of Illinois, they've predicted here, and again, the black line represents the number of hospital beds and really three potential actions that you could take. We don't do anything, which results in the red blob. And the red blob shows you that there's a peak of like 250,000 cases in the state of Illinois with something around 10,000 available hospital beds. So we just grossly exceed the number of available hospital beds if we don't do anything. If we only do the social distancing approach, which is here in orange, we still exceed that peak, not as far, and we extend the outbreak So we're over the maximum number of hospital beds available for a longer period of time, but by not nearly as much. And so we stretch the curve out. We flatten the curve, but we don't flatten the curve enough to actually minimize the number of mortalities that would occur. We look down here at the blue line. This is what happens when we do shelter in place for a long period of time. And basically, we never get close to that black line for the number of available hospital beds. So these kind of really restrictive contact measures, and we'll talk about why that contact's important in a minute, can stop from overwhelming hospital beds. And if you listen to the discussions out of Italy, right, they're now making decisions of saying who gets a respirator and who doesn't. And if you don't get not a respirator, who gets a ventilator and who doesn't. And those that are getting a ventilator, don't get a ventilator, probably are going to pass away. And so they're now in Italy saying, if you're over 60, sorry, you're too old. We're not going to try to save you. And I think that's really the concern of where we're at in the U.S., saying bad options morally. And so this is really going to be ugly. Now, if you notice in the upper right-hand corner, it says March 24th to 29th. You need to, this was our drop dead date in Illinois. If we didn't have intervention in place, the epidemic or this curve of cases would be ahead of where we're at. Now let's look at New York. And New York is the epicenter today. I think that's what's being reported of where outbreaks are occurring. And so here is New York. This is the same chart we had last time. What you'll notice here is that March 13th to 18th was the drop dead date. We implemented on March 20th a stay-at-home order in the state of Illinois. The stay-at-home order in the state of New York was implemented March 20th as well, which would be after their estimated date. So they said even because the outbreak was more advanced in New York, even if they implemented this 3 months of shelter in place, they were going to be close to that line if they implemented it early, and they implemented at the end of that. So it looks like they're going to bump above that, and they are probably already getting close to that. This is a really interesting conversation, right? Because now, even if they implemented it, they look like they're going to be behind. If we get really serious in New York, even though if they implemented it late, and we go to a 3-month style lockdown, which they did in Wuhan, which means nobody leaves their house, nobody does anything, there's nothing going on, which I don't think is morally or socially acceptable in this country. I don't think we'll tolerate that with our Constitution. They could probably stop it, but that's really a draconian approach. But as you look at this, it would take that level of activity to actually stop what's going to be the mess that's already occurring in New York City. And the stories coming out of there, particularly in the medical community chatter at this point, are pretty disturbing. I don't know if they're horrific, but they certainly are disturbing that they probably pulled the trigger a little bit late in terms of minimizing the impact of this disease. So I think our real concern with this whole activity is how do we minimize this overwhelming the hospital system? And I think certainly, as a professional and concerned and have watched the human medical system work, that's a concern for all of us. But maybe we take a step back and talk about where did this virus come from? And we use this word zoonotic disease, and that really means a disease that's moved between animals and humans. That occurs, unfortunately, more frequently we would like. We think most of the diseases that originated in humans came from another animal, and in some cases, disease that originated in animals. So porcine reproductive and respiratory syndrome, we believe, migrated from mice into pigs. And so this cross-species transmission is somewhat frequent. The difference is that it doesn't often take hold in the new species. So a virus moves from a bat to a human being, but the virus isn't well adapted and it doesn't replicate in humans, and it doesn't pass from human to human. So we go from being zoonotic to being pandemic or epidemic when we get the virus or the bacteria, and we're really worried about viruses, they get established in the human host and then can pass from human to human to human. And that's what appears to have happened here. And so cross-species transmission is very, very current. The ability to adapt to the new host they have is very infrequent, and that's a good thing, because this is what happens when we get a new disease in a population without any prior immunity. So I want to go and talk just 1 second about disease versus infected, and just let me mire into a bit of academic silliness here. But disease is this idea that I was exposed to some pathogen, and that pathogen, in this case infectious disease, pathogen caused me to have a response. I felt sick. We're exposed to pathogens or potential microbes, potential pathogens every day, all the time. We live in a mire of bacteria and viruses, but our immune systems handle that. So infected is different than disease. And that's really a key bit. And that's why all of this is a bit hard to understand, because we're really talking about, when we're measuring cases, is the most severe disease because somebody thought they needed to go to the hospital or somebody thought they need to be tested, not actually the number of infections. But these number of infections are really important because someone who's infected and shedding can infect another person. And that's one of the big differences between this coronavirus, which is officially named SARS-CoV-2, and the first SARS outbreak, which was SARS-CoV-1, which happened in China several years ago. That virus was much more severe, but it didn't transmit very well between hosts. And people who were infected were also diseased. So it was easy to tell who was infected because they were diseased. It is very apparent with this virus that we have a lot of infected people who are not diseased. And those infected people are infectious, meaning they can cause someone else to become infected without knowing it. And that's the thing we deal with in the animal world a lot, with a lot of animal diseases. And that's a critical difference in this disease compared to other diseases, and really why the transmission of this virus has been so crazy. So it starts to tell us, right, like, I don't know who I can be around and not get infected. And so that's why it's different, and why probably if you look at some of our early response, we're going to screen for temperature and we're going to do this and we're going to do that, those probably weren't very effective because people were infected and shedding, but didn't have disease, i.e. they didn't have a fever. So it gets back to this idea that when we're going to try to control disease, I really want to know where are all the potential sources of pathogens, i.e. where are all the infected, in this case, people at. In my world, where are all the infected pigs at? Where are all the infected cattle at? And if I don't know that, then my only choice is to stop contact, to stop movement. And so when we started this whole mess and we talked about testing, we didn't have enough test kits. And I don't want to get involved in the politics of how we got test kits out, but at the end of the day, we never have enough test kits to test enough people or enough animals or enough anything else to really know where the infection's at. And so they have some real challenges with understanding where we're moving, what are we doing, and therefore being more aggressive on control strategies when we don't have a vaccine becomes exceptionally important. There's one question here, and I'm going to go back and just answer this while we're going, and I'm sorry I missed it. It says, from the New York slide, I'm going to correct that they have more cases than hospital beds today. These are projections. These slides that I'm showing, this New York's hospitalizations over time, those are absolutely projections based on this article, which was published, the website, which was published March 19th.
Yeah, but they would be blue line. They're sheltering in place.
But they sheltered in place after the start date.
Okay.
And they probably haven't enforced the sheltering in take area like we'd like to see.
Okay.
So I drove into the studio this morning and there's people out walking around doing things. Well, that's probably not sheltering in place. And we've got this whole argument about what's essential people. We've had this running joke internally about a hashtag in our group, like hashtag I'm so important I should get the COVID. Really talking about how people are not being real bright about where they're going. And I think that's, yeah, so they're probably a little behind. I think they're certainly going to overrun the hospital beds in New York fairly quickly. So let's talk a little bit about control strategies and keep moving here. But when we think about control strategies, we really have got, when we think about controlling infectious disease, we got three buckets, and we're really trying to work on those three buckets. Every critter, human, pig, whatever, fit into one of three buckets. One of those is you're either infected with the disease, you're resistant to infection, or you're susceptible to infection. And when we have a novel pathogen, everybody's susceptible. And so control is about blocking infecteds and susceptibles contacting each other. So if I don't know who the infecteds are, it's really hard to keep the susceptibles from not being contacted. And that's really what all these strategies are around. How do I block infected susceptible contact? And I would really like to know who all the susceptibles are, or who all the infecteds are, because I can assume everybody's susceptible. Now we're quickly moving to a spot that if I had an antibody test and I knew who was recovered, then they would be in the resistant bucket, and maybe they could go back out in the workforce and do some other things. There's really three ways that we think about viruses or any pathogen moving around. We have animals and people. So if a person's infected, it's a direct host moving it around. Vectors, which are scary, and we think about things like yellow fever and malaria, et cetera, with mosquitoes. That's a not big issue here. We don't think there are any known vectors for this particular virus. And then the big funny word, which is fomites, which is physical carriers of disease. And so that's why we worry about surfaces and what's happening there. So we do know that fomites are a real risk. We do know that the virus lives on hard surfaces like glass or plastic for probably something in excess of 3 days. And then maybe on cardboard for less than 24 hours. And so we've got some work to do there, and science is trying to catch up. How likely is that virus to transmit along a given route? Well, the longer it's around, so time is always our friend. Time outside the host is advantageous. High or really low temperatures are advantageous. Low humidity is advantageous. Today it's 40 degrees Fahrenheit with 75% humidity. That's a really good day for viruses to transmit. So hopefully some sunlight or some warm weather will help us. And then UV light's really hard on viruses. So all this gets modified by what the environment is when we're outside and how successful we're going to be. When we think about disrupting transmission, we've basically got 3 buckets. Hygiene or cleaning and disinfection. It is by far the easiest to implement. It is exceptionally hard to get done. So if you look at some human healthcare studies work, we're about 50% efficacy in a hospital on getting our hands washed. So if human healthcare workers who are educated and understand the risk only get it done 50% of the time, I don't want to think about how effective we are at washing our hands every day in this case. The other 2 tools are hard to do, and we apply them to animal ag all the time, which include exclusion, meaning I'm just going to keep people out. This is what we really need to think about with nursing homes and really high-risk people. How do I just keep everything out of that nursing home to not put that nursing home at risk? And then we've got what we're really doing today, which is segregation. So let's keep everybody apart and not let them mix and not use those things routinely. And that segregation tool is really this idea of shelter at home. So we're not excluding everything. We're saying, hey, you got to get food, you got to do other things, but let's do that in a way that's less likely to have contacts between infecteds and susceptibles. So I appreciate your time today. I realize that was like a quick whirlwind tour. We could talk 7 or 8 hours about infectious disease control and policy and what's went right and what's been wrong, et cetera, et cetera. But as we talked about earlier, we've got certainly plenty of other online resources. If you go to online.vetmed.illinois.edu, that's our website, and you can certainly find we've got some podcasts that cover some of this material, et cetera, and some of our other courses. You can certainly follow us on Twitter at the Round Barn 1 Twitter handle. And if you have any questions, you want to contact me, iLearningVetMed, all one word, at illinois.edu is the best way to get a hold of me on email.